My name is Dr. Jacqueline Carter. I'm the medical director of the stroke program at Banner Desert. I've been here about 2 years. Banner actually recruited me to start the stroke program at Desert. And now that that's started, it's accredited by the Joint Commission, and we're in the top 15% of all stroke programs in the country. Where did I come from? Well, you can tell by my accent that I probably didn't come from Arizona. I hail from a state that begins with an A and ends with an A like Arizona. It's called Alabama. Did my medical training at Northwestern University in Chicago, Vanderbilt University in Nashville. And over the last 31 years, I have been in private practice. I've done teaching at medical schools, and done a lot of stroke work. Why am I interested in stroke? I think it's important that you know something about me. When I finished my residency at Vanderbilt, about a month afterwards, my grandmother had a stroke. And I don't know if you guys know anything about young doctors, but we're full of you-know-what and vinegar. We think we know everything. You know, we're the smartest and the brightest. I get in the ambulance with my grandmother. We go to the hospital, University of Alabama at Birmingham. They roll the gurney in and they put her in a corner. And we stayed in that corner for 8 hours until finally I could not take it anymore, and I went to the attending physician for the emergency room, and I yelled at him, and he looked at me and he said, "So what you want me to do? She had a stroke. There's nothing that we can do. You know that." And I vowed from that day forward that I would do everything that I could to prevent anyone from being treated like my grandmother. And that's how I became interested in stroke. Now that was 26 years ago. And every day since, I've made sure that I keep up with what's going on in stroke care. Why is stroke important? When I look around this audience, everybody in this audience, including myself, we're in that stroke demographic. Stroke affects about 800,000 Americans a year. Anybody want to take a guess at how much it costs to treat one patient? Come on, yell out. How much?
Megabucks.
Yeah, like the Mega Millions. Anybody want to take a guess? 30,000, low. 100,000, a little bit too high. Too low. $90,000 for each stroke victim for 1 year. Now, you take 800,000, multiply it by 90,000, that's $7.2 billion. I'm looking for that man so I can marry him. All right? $7.2 billion a year. So it's expensive. It is not the leading cause of death. Anybody know what the leading cause of death is? Heart disease. It is the fourth leading cause of death. But what is stroke number one in? Disability. More people are in long-term care nursing homes because of stroke. Not Alzheimer's disease, which you would think. Not heart disease, but stroke. So stroke is not a killer, but it is a significant disabler. When we look at the cost of taking care of one person with stroke, we not only look at the medical bills. Trust me, the doctors aren't getting $90,000, even though y'all think we are, okay? And the hospital's not getting $90,000, even though you probably feel like it when you see the hospital bill. Most of that money goes to the care that is required to take care of someone who can't be home alone. Now I'm going to put this down. What's the sign of stroke? What's the universal sign for stroke? Okay, if I do this, what's wrong with me? Oh, okay, good. If I go, okay. If I do that, think I got a headache, right? Okay? If I do this, I got a hip ache or a knee ache. What's the sign for stroke? Well, you know the symptoms, okay? But there is no universal sign for stroke. There's no way that someone can walk up to you and indicate to you that they're having a stroke. Okay? You're exactly right. That's why I'm going to go back here because these two ladies know a lot about stroke. 52% of the people in the United States over the age of 55 don't know one symptom of stroke. Did you know that? 52% know no sign of stroke. And as a physician, one of the things that happens is someone gets sick on a Friday night, and then they call a stroke alert on a Monday morning, okay? And I go down and I see the patient in the emergency room, and I go, well, what happened to you? Oh, no. Okay, so what's the first thing I ask them to do? Smile. And they look like this. Okay, then I say, raise your arm. One comes up. And then I say, do you understand me? Yeah. Can you say today is cool? Even though it's not in Phoenix. Yeah, it's cool. Then I asked them, when did this start? Friday night after I went to bed. This is Monday morning. Why did you wait so long? I thought it was going to go away. I thought it was going to go away. Why? Because a lot of the signs and symptoms of stroke you might have periodically. How many of you have gotten up with a numb hand or arm? Okay, good. How many of you gotten up and your leg buckled? Okay? Now, I think if you had slurred speech or you didn't understand what was being said to you, you might come to the doctor, right? Okay, good. I want to know that. But if you're out in the public, and I want you to tell this to your friends, your church members, your relatives, there are some ways that you can test someone for stroke. And this young lady had it both right. Fast. Can everybody in here spell fast? F-A-S-T. F is for face. You ask them to smile. A is for arms. You ask them to hold out their arms. S is for speech. You ask them to repeat something or to say something to you. And the most important letter in the word fast is time. T, time. You call 911. Don't call your daughter-in-law. Don't call your nephew. Don't go over to the next door neighbor and say, girl, can you come over here and check me? I think there's something wrong with me. And get in her car and come to the emergency room. You call the paramedics. Why do we want you to call the paramedics? Anybody got a guess? They know what to do. That's right. What else? Time's important. You raise your hand. Time is important. Why is time important? Great. There's some shot that they can give you to lessen the effect of a stroke. And that medication that we give by IV has to be given within 3 hours after the onset of symptoms. Not 3 hours after you get to the hospital, not 3 hours after you get in the car, but 3 hours from the time that the symptoms start. And that's why it's important that you call paramedics. Anybody in here got lights and sirens on their car? Okay. And we live in the county where Sheriff Joe makes you wear pink underwear if you violate the law. Okay. Anybody want to go 110 down Power Road? No. That's why we want you to call the paramedics. Time is important because every minute that the brain is without oxygen, you lose 2 million brain cells. Every minute. So what we're trying to do is we're trying to make the stroke smaller. We're trying to preserve as much brain as we can. And so neurologists think of time as brain. Time is brain. Yes, sir?
What can you do if you have a stroke and you're waiting for the paramedics? Can you take aspirin or something?
There's no harm in taking aspirin, even though we prefer you take nothing. The reason why we prefer you take nothing is because if you have problems like this, the aspirin can get stuck in your throat or it can go down your lungs. So we prefer that you take nothing. It's not exactly like heart attacks. If you got chest pain and you think you're having a heart attack, get the Bayer or the Walmart brand or whatever you got at home, okay? And take an aspirin or two. But in the case of a stroke, you may choke on that pill. So we prefer that you take nothing while you're waiting for the paramedics. The paramedics also are important because they call ahead, all right? Hi, we have a 62-year-old male who has evidence of a stroke starting about 15 minutes ago. The wife called. And so we know that you're coming. Now, if you show up at our emergency room, we call a stroke alert before you even get there. Stroke alert, brown zone, ETA, 15 minutes. So when you get to our emergency room, there's a doctor waiting on you. An emergency room doctor and generally a neurologist is waiting on you in the corridor as soon as you roll on through the ambulance bay. Okay? You do not go to a bed in our emergency room. You go directly from that corridor where the doctors examine you, you get an armband, and you go straight to CT, where we draw your blood, we put in your IVs, and we do your CAT scan immediately. The idea is, if you waited 20 minutes, if we can shave 10 minutes off the time that we use to get all the test results, then it makes it more likely that we can give you medicine faster. Our goal is to door to needle in 60 minutes or less. And right now we're at somewhere around 40. Okay? So, we want you to come in to get the medicine. What is this medicine, Dr. Carter? You keep talking about this medicine, this medicine, this medicine. What is it? The drug is called TPA. Okay? TPA. Now, if you have a loved one that comes in, you start asking, can they get TPA? Can they get TPA? Or if you don't remember the name, can they get that drug, okay, for strokes? Can they get that drug for strokes? And the reason why is strokes are caused by a occlusion or closing off of a blood vessel. 85% of strokes are caused by that. If the blood vessel is closed off, something had to close it off. It's like throwing a cue ball down your drain, right? Well, Drano doesn't dissolve a cue ball, but TPA dissolves the blood clot. Once we get the blood clot dissolved, then the blood starts to flow to your brain. All of your brain cells haven't died. Remember I told you 2.7 million in a minute? So we got billions to save. If we can open up that artery, then you will improve. Now, everybody's clear on that? Okay, I'm going to give you a chance to ask questions at the end. Okay. You guys know any risk factors? Why would you have a stroke? Why would you have a stroke?
Family history.
Good. Family history, diabetes, high blood pressure. Anybody else? Cholesterol. Anybody else? Weight. Good. Anybody else? Okay. Some of the things you named are what we call non-modifiable risk factors. Those, you know, in my plain English, you can't do crap about those risk factors. What are those non-modifiable risk factors? Well, one is age. You can't make yourself any younger. Well, that's modifiable. You can always stop drinking. And non-modifiable, ones that you can't change. You can't change your family history. You can't change your race. Well, you can, but you could be like Michael Jackson. Okay. Sex. Even though we have all sorts of people doing sex changes, if you were born a male, you're still a male. I don't care what you look like. Okay? You can't do anything about those things. Even though I know you want to divorce your ugly cousins, because I have some that I want to divorce too, wish they wasn't in my family. But if they had a stroke, I'm at risk. Okay? Those are non-modifiable risk factors. You can't change them. Most of the things you guys named are things that we can do something about. You can modify. High blood pressure, diabetes, drinking, smoking, being overweight. You can do something about those things. You can't help that you get high blood pressure. That's probably hereditary. But you can certainly control it. What is the ideal blood pressure? 120/80. How come you know so much? 120/80. All right? So if your top number is over 120, but less than 140, we sort of say that's primary hypertension. But if it's over 140, then we get concerned on the top. On the bottom number, if it's greater than 80, less than 90, okay, that's primary. That means it's sort of mild. But if it's over 90, then we're very concerned. Why is blood pressure such an important thing? Because blood pressure affects the small arteries of the body by making them harden prematurely. Let me repeat that. Blood pressure affects the small arteries in the body and makes them harden prematurely. Where are these small arteries? Well, you got them in your heart, you got them in your kidney, and you have them in your brain. So people with high blood pressure are predisposed to kidney failure. I'm sure you know people on dialysis. They had uncontrolled blood pressure. They end up on dialysis. Premature heart attacks or congestive heart failure, and strokes. The strokes caused by high blood pressure tend to be smaller than strokes caused by the cue ball getting in the plumbing. But it's still a stroke, and it still causes damage to the brain. And ultimately, if you have these small strokes, and I know you guys know about those mini strokes. This is not minis, okay? The minis are really what I call TIAs, and you call them mini strokes. These are small strokes in the brain. If you have multiple ones of those, eventually you have a disease that looks just like Alzheimer's disease. It robs you of your memory, your personality, and eventually your motor activity and your speech. So high blood pressure, it is important to know your numbers. Did anybody in here get that blood pressure checked today? Okay, before you leave, I want everybody to have that blood pressure checked. You need to know your number. All right? Any diabetics in here? I'll raise my hand. All right? Hypertension is the number one modifiable risk factor for stroke. Diabetes is number 2. Now, for my kin folks that have diabetes, do you cheat?
Sometimes.
Okay. That's what I wanted to hear. I don't know a diabetic in the world that doesn't cheat. All right? If you cheat, do what I do. I went to my doctor and I said, look, here's the deal. I love Coca-Cola. All right? I'm going to have Coca-Cola. So you have to manage my sugar with my Coca-Cola. Give me the drugs that are going to make my sugar go down in spite of the fact that I'm going to drink that Coke. Now, I don't drink a Coke every day, but I want to be honest. Because if you aren't honest, how can we help you? Now, you guys know what you do, okay? Not only the diabetics, but you know when you go into the doctor, if you got a high cholesterol, you won't eat a steak that night, okay? You won't have a fat burger, all right? You know better. What do you do the night before you go to the doctor? You have a salad with some tuna fish. So when you go to the doctor, you know that cholesterol looks pristine, all right? That doesn't help us. We need to live where you live. If you're eating hamburgers and steaks and pork chops and ribs 4 or 5 times a week, we need to manage you like that. Don't clean up just to come to see us and give us a false impression. We need to see you at your worst so we can manage you in that state. And you need to communicate. I don't know how many doctors ask you, well, what's your diet? Anybody's doctor ask them that? Nobody raised their hand. Oh, your doctor asked you? What's your diet? Your doctor asked you? Oh, I said, nobody in here, I believe, has a doctor that says, what is your diet? What do you eat? That's a rare question coming out of a doctor. Mainly because we waltz in the room, we spend about 5 minutes. Okay? Find out what you need, and then we're out of there. But if we don't ask, you should say, hey, Dr. Carter, hold on a minute. Let me ask you a question about my diet. Now, what do you like? What's your favorite food?
Beef steak.
Beef steak. Now, Dr. Carter, I like beef steak, and I have one about 4 times a week. Is that okay? All right. Then I can counsel you. I can say, well, what's your name?
Barry.
Well, Barry, 4 beef steaks a week might be a little bit much. Could you cut it down to 2? And then the next time you come in and you say, I'm down to 2, I'm going to ask you to cut it to 1. I'm not going to ask you to sacrifice all at once, except cigarettes, but we'll get into that later, okay? All right. So you need to discuss with your doctor what you really do. Don't try to fool us. Then we cannot help you as well. All right? Diabetes, like high blood pressure, attacks those small arteries in the brain, the kidney, and the heart. It is a risk factor for stroke. It mimics high blood pressure. If you have high blood pressure plus diabetes, then your risks are increased. Everybody's with that? Okay. Heart disease. Anybody in here ever heard of atrial fibrillation? You've heard of that. Okay. You have it? All right. Atrial fibrillation is a risk factor for stroke. Do you understand why? Okay. All right. Anybody in here want to explain atrial fibrillation, or you want me to do it? Okay. You have 2 chambers in your heart, right? On the left side, you have a top chamber and you have a bottom chamber. The bottom chamber is like my belly. It's sort of fat. The top chamber is like my head. It's not that big. Atrial fibrillation means that this part is just shaking. It's shaking, just like a bowl of Jell-O, just constantly quivering. If it's constantly quivering like that, then the blood gets in there and it just sort of seeps out like air through a tire that has a hole in it. It seeps out. But it doesn't all go out. Some of it stays in there. Okay? And when that blood stays in there, then what does it do? It forms clots. Now, every now and then, even though your heart's quivering, it's quivering like that. All of a sudden, it'll stop quivering and whoosh, give a big stroke. Push everything in it out. Okay, clots and all, which comes out down to the lower chamber. From the lower chamber, it goes to the aorta, which is the main artery in the body. And then from there, it goes to the brain. The brain is the mafia of the body. The first 25% of all the blood that comes from your heart goes to your brain. The rest of your body has to live off 75%. So the brain is going to take its insurance money right off the top. As a consequence, those clots that come out, when you have that push out of blood from that quivering chamber, goes where? To the brain first. It gets there first. And after that, it becomes a random walk. It can go on this side, or it can go on that side. It can go in the front. It can go in the back. We don't know. But when that chamber empties, and it empties those clots, it causes a stroke. Now, anybody that has atrial fibrillation, they talk to you about a blood thinner, don't they? Okay? The most common blood thinner we use is Coumadin. How many people have I had say to me, I ain't taking that rat poison. I ain't taking that. That's rat poison. You had a question. Somebody had their hand up. You take Coumadin? Okay. So what I'm going to spend a little time on is we got to thin your blood because we don't want those clots forming in your heart. That's the purpose of the blood thinner. But there are some newer agents out now. Anybody that's on Coumadin knows not only do you have to take the pill, but you got to do what? Oh, God. You're going to get your blood checked at least once a month, aren't you? Twice a month for you, so you're even worse than most people. And then the doctor says your INR is too low, so you got to raise the dose. Then you get it done the next time, it's too high, then you got to lower the dose. And so you're all over the place, okay? Constantly maneuvering your drugs. The newer drugs that are out are either pills that you take once a day or twice a day, and they do not require any blood test. And that's because when you take the pill, one dose thins the blood. We don't even measure it. There's no need to go get an INR. So it's convenient. But our problem is that most of those drugs we cannot reverse. The risk of taking any kind of blood thinner is that it can cause you to bleed. And I'm not just talking about bleeding in the brain, which is what people commonly think of, but you can bleed in the gut, you can bleed in the urine, you can bruise easily. All of those could be complications of thinning the blood. And as a consequence, if we can't reverse it immediately, then we have some pause in terms of prescribing it. But those drugs are gaining favor because at least one of those drugs now has an antidote or has something that we can use to reverse it. So if you have atrial fibrillation and you're on Coumadin or rat poisoning, then you may want to discuss with your physician whether or not you would be a candidate for some of the newer agents. Okay? Xarelto. Yeah. Right. Okay? So I didn't want to get into brand names. I was just trying to slide over, gloss over it in general without advertising for anybody. So if you have atrial fibrillation, that's the #1 heart disease that puts you at increased risk of stroke. Anybody know about congestive heart failure? Anybody got congestive heart failure? Congestive heart failure, okay? Congestive heart failure means that the muscles of the heart, particularly of the left ventricle, get sort of saggy. Now, women that used to wear pantyhose, you know how the pantyhose would sag? Well, that's how your heart gets. It gets saggy, it gets baggy, and when that happens, it doesn't contract well. And when the heart doesn't contract well, fluid builds up in your body. So it comes in to the right side of the heart, it goes to the lungs, it comes to the left side of the heart, but it can't get out very well. So the first thing you do is you get fluid in your lungs. The second thing that you get is you get fluid in your legs, because then your legs swell up during the day, but when you lay down at night, they go down. That's a common symptom of congestive heart failure. When you have congestive heart failure, because the heart is not pumping correctly, you get clots in the heart itself. The heart is not efficient, and then in the lower chamber of the heart, the same thing can happen. The clots can pass out with the blood, and then that can cause a stroke. Similarly, if you have a heart attack, and that damages the heart, then you can have a stroke. So heart disease is the #3 modifiable risk factor for stroke. Now, someone said weight and exercise, right? Weight and exercise. Anybody in here exercise every day? Yay! That's probably why all of you are in here. All the fat, non-exercising people stayed home. Exercise is not only important for weight control, but it helps to keep your heart healthy, and it helps to keep your blood vessels healthy, and it helps to keep your brain healthy. It has been shown in studies that people who exercise at least 30 minutes a day, 3 days a week, that's 90 minutes out of the whole week, have a lower risk of heart disease, heart attack, stroke, and Alzheimer's disease. People who are active are less likely to get some of the more debilitating illnesses as we age. So I encourage everybody to exercise. You can exercise and be healthy even though your weight might not be what it should be. But all the other parameters will be normal, and as long as you're exercising and you're moving, it is very beneficial. So you got to keep moving. Sometimes your knees hurt, sometimes your ankles hurt, sometimes your hips hurt, but we want you to keep moving. What is moving? Moving could be swimming. If you have arthritis or a bad back and you can't walk very far, you can get in that water and you can swim. You don't have to bear any weight to do it. If you can walk, great. We want you walking at least a half hour 3 times a week. You want to lift weights? Free weights? Yay! Lift those weights. We want you doing that too, because all of that helps to keep you healthy. Drinking. Somebody mentioned drinking. Okay? I don't know who it was. I don't remember now. It was you? Okay. Alcohol is a double-edged sword. It has a good side and it has a bad side. So we'll start with the good side first. Women can have 1 cocktail a day. Okay? I don't mean a 12-ounce bottle. I'm talking about some, you put in like a 6-ounce glass with 1 jigger of alcohol, or a glass of wine, or 1 beer a day. That has been shown to be protective of the blood vessels and the heart and even the brain. Women, 1 drink. Guys, 2 per day. When you go over that, you exceed the benefit. Now, I used to work in Milwaukee. You guys know anything about Milwaukee, Wisconsin? Okay. Milwaukee, Wisconsin is the drunkest city in the United States. You show up on Wednesday, and you sober up on Sunday morning in time to go to Mass. They have a long happy hour. So I would tell my patients, okay, you can have 14 drinks a week. Then I'd see them a month later. Oh, you'd be so proud of me, Dr. Carter. I kept my drinking to 14 drinks all on Friday and Saturday. You can't drink them all at once, guys. You can't store them up. And ladies, you can't store your drinks up and use them all on one day. You have to spread them out. Yes, ma'am.
You say, like, you can have wine. Do you mean a cupful?
Yeah. Yeah, I mean a glass of wine. Yeah. Yeah, and 1 cup full for a lady. Okay? No. If you didn't do it, don't start it. Okay. Okay, well then don't start. All right? No, I don't want you to. Okay? Don't start. If you don't drink, don't start drinking just because alcohol can have some beneficial effects. But if you do drink, then I want you to modify your drinking accordingly. Women, 1 drink a day, men 2. Okay? Recreational drugs. You guys know what I'm talking about? Everybody's giggling. Okay, what does recreational drugs mean? Marijuana, cocaine. They got some new ones out there now that I look at and I go, ooh, I need to retire. They're creating these things that I don't even want to deal with anymore. Again, risk factors. Most people who use cocaine don't realize that it causes aneurysms in the brain and it causes brain bleeding. The same thing is true for methamphetamines. Causes hemorrhages in the brain. Marijuana, we don't have any evidence that it causes any deleterious effects. Any drug that you inject IV, heroin, cocaine, anything, can cause bacterial infection of the heart. That bacterial infection can break off in the form of a clot and close off a blood vessel, or it can go to the brain and cause a rupture of the blood vessel. So drugs are also an important factor. Cholesterol. If you come into our hospital, we're going to make sure that we check your lipids. We're not so much interested in your total cholesterol, okay? They say, well, Dr. Carter, this patient's total cholesterol is 450. And I'm like, okay. That's something for the family doctor to worry about. What does Dr. Carter worry about? The LDL. LDL is your bad cholesterol. The way I want you to remember it is the bad one, you want it to be low. Okay? Low, LDL. The good one, you want it to be high, HDL. Okay? So you want good to be high and bad to be low. All right? We're concerned if you come in with an elevated LDL of greater than 100. We're going to treat it. We're going to treat it fairly aggressively. We're also concerned about your HDL. If you come in with an HDL of 30 or less, we're going to be concerned about that. And we're going to put you on an exercise regimen, probably give you some fish oil, and try to see if we can get that HDL up. The total cholesterol, on the other hand, is driven by other factors, including the triglycerides and some other types of DLs that don't concern us as much. But we're very concerned about the LDL and the HDL. Yes, ma'am. Yes, ma'am. Yes, ma'am. And we want the HDL, if we can, to be 50 or higher. Okay? In terms of stroke risk. Tobacco smoking, another modifiable risk factor. I told you I was going to talk about that, and I am. Tobacco smoking long-term causes hardening of the arteries, both of the small arteries and the large arteries. Again, what does that put you at risk for? Heart attack and stroke, as well as kidney failure, eye disease, in addition to the things that you know about like lung and mouth cancer. Okay? So, if you smoke, we'd like for you to quit. If you don't smoke, we don't want you to start. All right? So smoking or tobacco usage is important. It's not only smoking, it's also, chewing. Okay? We don't want you to chew either, because that also causes carcinoma and it causes changes to the blood vessels. And we don't want you to dip. I'm getting to all forms of tobacco that I can. No dipping, no chewing, and no smoking. Okay, so we've talked about some of the things that you can modify, and we've talked about some of the things that you cannot modify in terms of what you can do to prevent stroke in you as an individual. Why does this become important to us as a community? Well, we just came through what I call hell, government hell, because of the government closure. And the government closure, by and large, is being driven by the debate about health care. But that's not really the issue. The issue is what? Debt and deficit. If we're spending $7.2 billion a year on a disease that affects less than 1 million people, and people like me, the baby boomers, are entering their prime, that they're going to be retiring at the rate of over $2 million a year, what do you think is going to happen to health care costs? We aren't going to be able to afford it. 10 years from now, it won't just be Medicare that's bankrupt and Social Security that's bankrupt. If we keep on the trail that we're on, the country will be bankrupt, trying to take care of all the illnesses that come with a very large aging population. And that's why it's important for people like me to get out and talk to you. Because you are the ambassadors. You get to spread the word. Now you know something about stroke, don't you? You know, like that 52% of all the other Americans. Okay? You know what to look for. You know about FAST. You know that you can't change your kin, your sex, and all of that. But you also know the things that increase your risk of having stroke. If you, each one of you in this room, could tell 2 people, it's like that game you played when you were kids, telephone. You guys ever play that? Okay. You start a lie at the beginning of the room and wait till it gets to the back row and see if the lie has changed. Okay? Well, if you tell 2 people and they tell 2 people, eventually a lot more than 48% of the people over the age of 55 will know what are the signs and symptoms of stroke. More importantly, if you teach them fast, they'll also know what to do. call 911. Now, I'm going to open it up for questions. I've tried to be very broad because everybody has a doctor, and I'm not here to be doctor today. I'm here just to share information. Yes, ma'am. She has a question about people who have had small strokes, multiple small strokes, and the fact that that can mimic Alzheimer's. Alzheimer's is a dementia. You guys know it's Alzheimer's dementia. Dementia is a category of disease that says your cognitive skills, your thinking, and your ability to process information may be impaired or is impaired. It's not just about memory. Most people think it's just memory, but it goes way beyond memory. You know, the ability to balance a checkbook or remember if you paid the house note, where you put your car keys is important. Getting lost on the way home, that's not all memory. That's cognition. When we have a person with dementia, doesn't mean it's Alzheimer's. There are lots of things that can cause dementia. Vitamin B12 deficiency can look just like a dementia. It's completely reversible. Folic acid, thiamine deficiencies, brain tumors, hardening of one artery where you have slow blood flow, particularly to the left side of the brain. That can all mimic Alzheimer's disease. Alzheimer's is not the only dementia. When you have multiple small strokes in the brain, they tend to occur at random. A piece here, a piece there, a piece there, a piece there, and eventually they add up. Okay? The more I take out, the less you can do. So your brain looks more like Swiss cheese as opposed to looking like cottage cheese. That means then that you're at a point where you have so few connections to various parts of the brain that you cannot adequately process information. And you look exactly like an Alzheimer's patient. And we would think you had Alzheimer's disease until we do a CAT scan, our magic test. And then we see all these holes in the brain, and we realize that you have vascular dementia, which is another type of dementia. Transient ischemic attack. They're important. If you have one, don't stay at home, because the likelihood of you having a stroke within 30 days is very high if you've had a TIA. Even for the first 90 days after one TIA, your risk of stroke is very significant. That's God's way of giving you a warning. Don't be like the man in the tree. You heard about the guy with the floods, you know. The flood came, and the man, everybody said, "Come on, bud, let's go." And packed their cars, and they were leaving. And he said, "No, God will take care of me." The water started rising. He went to his second floor. He was hanging out the window. The boat comes by. "Come on, guy, we're here to rescue you. We're the National Guard. Come on, get in the boat." "No, God will take care of me." He went up on the roof and climbed the tree. The water kept rising, kept rising, kept rising. Helicopter came. "We're here to rescue you." "No, God will take care of me." Next thing you know, the guy's in heaven looking at God, and he's like, "Why didn't you take care of me?" God said, "What did you expect me to do? I said, a boat, a helicopter?" Okay? I don't want you guys to be like that with your TIAs. I don't want you to take them for granted. It's God's way of warning you that there may be something very, very wrong in your brain or in your neck or in your heart, and you need to go see somebody. If you have a TIA, if you have any neurological symptoms that we mentioned, sensory loss on one side that came on suddenly is also a reason to go. Problem swallowing, blurred or double vision, staggering like you're drunk, even though you're like him, you never drank. Okay? All right? Any of those symptoms that come on, in addition to face, arm, speech, get your butt to the hospital immediately. Because we don't know if those symptoms are going to go away in an hour, do we? You don't know it until they go away. So for all intents and purposes, you're having a stroke, a mini stroke. If they go away, you can call it a mini stroke. I call it a TIA. But I always think of it as a warning or a forewarning of something bad that may be occurring in you. And we encourage you to come immediately to the emergency room, the same as you would if you woke up with a deficit. Okay? Yes, sir. That's completely true. Again, we have a 3-hour window from the time of onset of the symptoms, and the drug that we use is TPA. But if you can't remember TPA and you call it PAT, it doesn't make any difference. Just say, I want that stroke drug, okay? All right? Yes, ma'am. What about an aspirin? Can you take aspirin? That's right, okay? And anyone who's had a TIA, well, actually, I'm a little crazy. I tell all my patients, 55 and older, take a baby aspirin every day, okay? If you're 55 and older, just take the aspirin. Forget about it. We should put it in the water. They should have 55 and older bottled water that includes aspirin and cholesterol medicine. All right. Yes, ma'am. Okay, let's talk about that, because I really didn't talk about hemorrhages, did I? Okay. Severe headache. We like to think of it as a thunderclap headache, the worst headache that you've ever had in your life, but that's not necessarily true. Severe headache is a sign, or can be a sign, of bleeding in the brain. There are 2 ways that you can bleed in the brain. One is something called a subarachnoid hemorrhage that is caused by a rupture of an aneurysm. Okay? Ruptured aneurysm is a type of stroke. Fortunately, the hemorrhagic strokes only account for about 15% of the strokes that we see. They're not that common. But they are also the most deadly type of strokes that we see. The mortality rate is much, much higher if you bleed in your head than if you come in and we have to give you the clot buster. So, if you have a severe onset of the worst headache that you have in your life, and particularly if you become nauseated or lose consciousness or something like that, call 911 or have someone else call 911. Because at any age, you can have a ruptured aneurysm. From teens to hundreds. We see them at all ages. A subarachnoid hemorrhage has a mortality rate, if it's a large hemorrhage, of about 75%. That means 75% of the people that get it die, 25% survive. And a lot of those people who survive don't survive well. The other type of hemorrhage that we have is an intracerebral hemorrhage. And that's why it's important that you know your numbers. Because intracerebral hemorrhages are commonly caused by a big spike in blood pressure. So when we see someone that comes in with a blood pressure of 230 over 125 or 130, we're really concerned that they may have bled in their head. When you have that type of hemorrhage, it tends to be deep in the brain and it tends to be inoperable. So your survival depends on your connection with the higher power. We can't go in and evacuate those. And we have to wait on God or whoever the higher power that you believe in to do his or her thing. I say her thing. Okay. And allow the blood to be reabsorbed. 15% of all stroke victims are hemorrhagic. Out of the mortality rate for stroke, however, that 15% accounts for about 50% of our mortality. Yes, ma'am. Okay. That's a good one. We talk about fast. When I digress, but I like these little stories so you remember. When I was in Milwaukee, I was in the Tony part of town, you know. And so I used to teach the Suttons, because everybody understood the Suttons. When I got there, they were teaching the Suttons. You know, those people were like highly educated, and they didn't have no time for no fast. They wanted to know the whole truth and nothing but the truth. So I would tell people the sudden onset of loss of vision, double vision, blurred vision, that would be one of the Suttons. Sudden onset of numbness, tingling, particularly on one side of the body. Sudden onset of weakness, sudden onset of clumsiness or staggering. Sudden onset of problems swallowing. I would go through this whole list of suddens. Sudden onset of a severe headache. Okay? But then I would move to Kentucky. They were not Tony. So we came up with fast. They can remember fast. They couldn't remember them suddens. So, doctor, what you say about sudden what? So for our Kentucky natives, we came up with fast. and they understood that. Fortunately, FAST has been adopted by both of the stroke associations in the United States. So the National Stroke Association and the American Stroke Association, one was teaching SUDDENS, one was teaching FAST. Now they all teach FAST because it's easy to remember. Now, to answer your question, the brain has an occipital lobe right about here, and that's your primary visual cortex. Now, that tells your mind or you what you're looking at. It doesn't actually see, but it tells it that this is a chair, or this is a man in a white shirt, or these are my eyeglasses. The seeing part of the brain is in the brain stem. That's where the fibers go back and you see the object, but you have no clue what the object is. So if you have an injury to the occipital lobe, then you can have visual changes. If you have a lesion in the connections between the brain stem, where primary vision is, and the occipital lobe, you can exhibit visual problems. You can also have a stroke of the eye. Okay? There's an artery in the eye that you can have a stroke, just in that artery, and then that can cause you to lose vision. And the most ominous thing you can have is loss of vision in one eye where it feels like a shade is coming down over your eye. That's ominous, because that indicates that this artery, this main artery that supplies 2/3 of your brain on one side, is closing. If you have that shade coming down over one eye, you hop, hippity hop, hop, and call 911. Okay? And then those patients are candidates to have an endarterectomy or a surgery where we open up this artery and do a roto-rooter job on it, close it back up before you have a massive stroke. Because if that artery closes off suddenly and it closes off completely, then you lose all of this on one side of your brain. That's not something that's recoverable. We can't rehab that. It's too much damage. Other questions? Okay. There's anybody in here on statins, Lipitor? Okay. You know, that should be in the water too. I told you we should have over 55 water, aspirin, and some statin, Lipitor, Pravachol. Something should be in the water, simvastatin. Because not only do they lower your LDL, but if, God forbid, you have a second stroke, they increase the likelihood that you recover. And they make the deficit smaller. There's evidence to show that. So if if you're on a statin, stay on a statin. I know there are some complications with statins, memory loss, muscle aches, muscle fatigue, muscle pain. Those things you need to discuss with your physician. But if you aren't having any side effects from the statin, then I highly recommend that you stay on your statin. There are some alternatives. They aren't as good as the statins, but everyone can't take statins. And we don't know who you are until we give you the drug. And then if you come in complaining, then we know, oops. Okay, but we can't go oops beforehand. Yes, sir? Yes. Yes, sir. Yes, sir. Yes, sir. Unfortunately, that's how it is. Got to do that delicate dance. He says wine is good for your heart, but if you have diabetes, it's bad for your diabetes. Do you have to balance one against the other? And the answer is yes. You do have to balance one against the other. You have to do that delicate dance. Yes, sir. You look good, son. Come on.
I take no medication,
Whew.
but I like Dr. Pepper. I drink a lot of Dr. Pepper,
How much is a lot?
like a liter a week.
Okay.
Is that too much?
I'll let you slide with that.
Is that okay?
Just a liter, not 2 liters, not the big bottle, just 1 liter. Oh, that's 2 liters. Okay, you can slow your roll a little bit. Okay, if you cut that in half, I'd be a happy camper. Most of us, as we age, we get aches and pains. You know, we get a little gimpy sometimes, something to give here and something to give there. That's a function of aging. That's not a sign of a stroke. If, on the other hand, you're walking and all of a sudden your leg is real heavy, okay, then you need to start walking and get out the cell phone. Everybody in here ought to have a cell phone if you're exercising outside of your home, because you can call 911 from your cell phone. Okay?